بسم الله، اتفضل يا بروف.
طيب السلام عليكم ورحمة الله. We are starting again. We already covered this part, but we are going to cover it very quickly. We talked about the sensory system consisting of receptors, afferent or sensory neurons, tracts, and sensory cortex. We started to talk about the receptors. Very quickly, the receptors are classified by different types of classification. They are special structures found at the terminal end of the afferent neuron, and they are classified according to their detection of the site of event. For example, if the receptors are detecting distant event, they are known as teleceptors. Like the visual receptors, usually they detect this distant event. Exteroceptors, they will detect touch, for example, on the skin. So they detect events occurring at the immediate external environment. And interoceptors, like baroreceptors and chemoreceptors, they are detecting events occurring inside the body. And we have proprioceptors for detection of the movement of the body. They are found in the joints and tendons and ligaments. So this classification is according to the site of event. The receptor will detect the site of event. We have traditional classification, old classification, whether the receptors are found in the skin, they are cutaneous receptors. If they are found in the internal structures, are visceral receptors. So when we talk about baroreceptors are both visceral receptors and they are baroreceptors also. They are interoceptors. And according to the type of the adequate stimulus, the type of the receptor, the type of the energy to which the receptor is most sensitive, usually we can classify receptors into mechanoreceptors, thermoreceptors, chemoreceptors, baroreceptors. Mechanoreceptors, they will detect the mechanical energy or stimulated by the mechanical energy. Chemoreceptors, they are stimulated by chemical stimuli. Baroreceptors, they are stimulated by pressure. So again, when we talk about the baroreceptors, they are baroreceptors because they are stimulated by the blood pressure, and they are interoceptors because they are found inside the body, and of course they are visceral receptors because they are found in the internal structure of the body. So this is according to the different types of classification. Additional classification is the structure of the receptor, whether it is free nerve ending, whether it is encapsulated, or whether it is expanded tip. Usually the free nerve ending will detect pain and temperature. The encapsulated and expanded tip are specialized. The touch, usually detected by Bassinian corpuscles, which are encapsulated. Vibration is detected also by Bassinian corpuscles and Meissner's corpuscles. Both of them can detect vibration, and it is specialized also. And Merkel disc and Raffini endings can detect proprioceptors, for example. So we have different types of receptors and different types of classification. Again, I will give you an example. When we talk about, for example, the chemoreceptors. Chemoreceptors are interoceptors because they are detecting inside the structure, and they are stimulated by chemical stimuli in the body. And usually the chemoreceptors are visceral receptors because they are found in the internal structure according to another type of classification, and so this is how to classify the receptors. And then we talked about the characteristics of the receptors. We mentioned three features of the receptors. The adequate stimulus, already we talked about it. The adequate stimulus is the type of energy to which the receptor is most sensitive. Baroreceptors are stimulated by pressure. Chemoreceptors are stimulated by chemicals. Mechanoreceptors are stimulated by mechanical energy. So the adequate stimulus for touch is mechanical energy. The adequate stimulus for the rods and cones in the eye is the electromagnetic energy, the light energy. So that's the adequate stimulus. It is very easy and straightforward. Excitability, also we talked about excitability in the last Friday, if you remember. We mentioned that the receptors, being part of the neuron, they can be excited, and the excitation will be by sodium influx or calcium influx. The excitability will, usually local potential is generated, not action potential immediately. Usually when you excite the receptor, action potential is not generated immediately. There should be local potential known as receptor potential or generator potential. These will be summated to give the action potential. Okay, and we mentioned 4 differences between the receptor potential and the action potential. We mentioned that the receptor potential is stimulated by subthreshold stimulation, and the action potential is stimulated by threshold or suprathreshold stimulation. We mentioned receptor potential is local, action potential is propagated or conducted through the axon of neuron. Receptor potential can increase and decrease according to the intensity of stimulation. Action potential is all or none. And receptor potential can be summated, action potential cannot be summated. We mentioned that in the last lecture. These 4 differences between the action potential and the receptor potential. Last feature is the adaptation. Some receptors will adapt rapidly, known as phasic receptors, like touch. Some receptors will adapt slowly. They are known as tonic receptors. And some receptors will never adapt, like pain receptors. So this is different classification according to type of field. The afferent neurons or the sensory neurons may arise from the skin or from the internal structures. Usually from the skin they are known as somatic neurons. From the internal structures they are autonomic neurons or visceral neurons. Okay, so this is the afferent neurons. Now we come to the sensory tracts and sensory cortex. As I mentioned, the sensory system includes receptors, sensory neurons, tracts, and sensory cortex. So now we will talk about the tracts and the sensory cortex. Okay. So this is the area where actually we stopped with the first group. Now we are going to continue from this area. The sensory tracts, we have 2 sensory tracts. We have dorsal column tract and spinothalamic tract. The dorsal column tract usually will go through the dorsal part of the spinal cord, and the spinothalamic tract will go through the anterolateral part of the spinal cord. That's why it is also known as anterolateral tract. And from the name, it is spinothalamic. That means it from the spinal cord, it will reach the thalamus. That's why it is spinothalamic, and it is ascending. It is going up, not like the motor tracts which are descending. Corticospinal is descending, so it is motor. But spinothalamic is ascending, so it is sensory. The dorsal column tract will carry fine touch, pressure, vibration, position sense, and 2-point discrimination. Okay, you have to memorize this actually. Fine touch, pressure, vibration, position sense, and 2-point discrimination. Okay, and usually the afferent neuron which will carry these sensations to the tract are A beta. Usually the afferent neurons are classified into A, B, and C. And A is further divided into A alpha, A beta, A gamma, A delta. A alpha and A gamma are motor neurons. We are going to talk about them, inshallah, in the motor system. A beta and A delta are sensory neurons. Okay, A beta usually for this type of sensation, fine touch, pressure, vibration, position sense, 2-point discrimination, all of them are carried through A beta fibers. Okay, spinothalamic tract sensations like crude touch, temperature, pain, itching sensation, sexual sensation, all these sensations, especially pain and temperature, they are carried through type C and A delta. Type C and A delta fibers. So again, usually the neurons are classified into A alpha, A beta, A gamma, A delta, A alpha and A gamma motor neurons, A beta sensory neurons, and A delta sensory neurons, and type C sensory neurons. A delta for pain, temperature. A beta for fine touch, vibration, and position sense, proprioception. Okay, and C for pain and temperature. Okay, so A delta and C for pain and temperature. These are the afferent neurons. So the afferent neurons usually will come. We are talking about the tract. So the fine touch, pressure, vibration, position sense, 2-point discrimination in the dorsal column tract. And the dorsal column tract consists of 3 neurons. First order neuron, second order neuron, third order neuron. Okay, you can actually study the description of the tract in the book, but I'm going to mention very important information. First information is the types of sensation carried through each tract. Okay, fine touch, pressure, vibration, position, 2-point discrimination. You have to memorize that. Second thing, the second order neuron is the neuron that crosses to the other side. Because this sensation is carried towards the opposite sensory tract. Sensation from the right side will go to the left sensory tract in the cerebral cortex. And sensation from the left side will go to the right side of the cerebral cortex. Okay? So it is carried to the opposite side of the sensory tract, and crossing to the opposite side occurs in the medulla, not the spinal cord. For the dorsal column tract, it will be carried through the same side in the spinal cord. It will cross to the opposite side in the brainstem. This is very important because we are going to talk about hemisection of the spinal cord. When we talk about hemisection of the spinal cord, we have to know which sensation is lost on the same side, which sensation is lost on the opposite side. Now you know that hemisection of the spinal cord will cut the dorsal column tract of the same side. So you are going, the patient is going to lose which type of sensation? I'm asking about hemisection of the spinal cord on the right side. Right-sided hemisection of the spinal cord will result in loss of which type of sensation on the same side? Fine touch, pressure, vibration, position sense, and 2-point discrimination. Dorsal column tract sensation. Why? Because the dorsal column tract is carried through the same side in the spinal cord. Let's go to the spinothalamic tract. As I mentioned, the spinothalamic tract, usually the afferents are A delta and C fibers. It carries crude touch, temperature, and pain. These are the most important. Let's talk about pain and temperature. Okay. And crude touch also, sometimes they ask about it. Also, it consists of 3 orders of neurons: first order neuron, second order neuron, third order neuron. The second order neuron will cross to the opposite side, like the dorsal column tract, but crossing to the opposite side occurs at the spinal cord. So the crossing to the opposite side occurs at the spinal cord. That means when the spinal cord, when there is hemisection of the spinal cord on the right side, usually pain, temperature on the same side are preserved, but pain, temperature of the opposite side are lost. Okay? Again, if there is hemisection of the spinal cord on the right side, so from the right side, the spinothalamic tract is not affected because the spinothalamic tract will cross to the opposite side. But the spinothalamic tract of the left side will go on the right side, so it will be affected. That means the patient will lose which type of sensation? On the left side, temperature and pain. So for the last time, I'm going to repeat it. This is for the last time. The dorsal column tract sensations are carried through the same side of the spinal cord. The spinothalamic tract sensations are carried through the opposite side of the spinal cord. So whenever there is hemisection of the spinal cord on the right side, the patient is going to lose his dorsal column tract sensation on the right side and his spinothalamic tract sensation of the left side. So the right side, there is loss of fine touch, vibration, position, sense, 2-point discrimination. From the left side, there is loss of crude touch, temperature, and pain. Okay, this is the tracts of the spinal cord, the sensory tracts. Very important to revise. There are additional information. Actually, when you read the book, you will find it. For example, when the spinothalamic tract crosses to the opposite side, usually the fibers will go anterior to the central canal. I assume that you know the central canal in the center of the spinal cord. And the central canal sometimes contains cerebrospinal fluid. Sometimes it may be dilated in a disease, congenital disease known as syringomyelia. In syringomyelia, there is dilatation of the central canal. So when the central canal dilates, it is going to damage the spinothalamic tract. But the dorsal column tract is not affected because only the spinothalamic tract comes in front of the central canal. And because of that, the patient is going to lose pain and temperature, while fine touch, vibration, position sense are not affected. That means he will develop dissociated sensory loss. So dissociated is opposite to associated. So these sensations are not associated together in the damage. Usually they are dissociated. So we have loss of pain and temperature, preserved fine touch, vibration, and position sense. It is very important sign known as dissociated sensory loss, and it is found in syringomyelia, where the central canal is dilated to affect the fibers of the spinothalamic tract, not the fibers of the dorsal column tract. So this is about the sensory tracts. As I mentioned, you have to revise. And also, usually pain will come into substantia gelatinosa. The dorsal column tract is divided into laminae, lamina 1, 2, 3, 4, 5, and 6. And usually lamina 2 and part of lamina 1 or part of lamina 3 will receive the dorsal column, the spinothalamic tract, like pain and temperature, only the anterior part. And 4, 5, 6 will receive the dorsal column tract, usually protection like that. So usually remember that usually the 1, 2, and 3, especially 2 for pain, and it is the gate for pain. We are going to talk about substantia gelatinosa, which consists of lamina 2 and part of lamina 3. It is the gate for pain. We are going to describe it when we talk about pain. So we can go now to the yes, there is another also important information about the arrangement of fibers within the tracts, especially the spinothalamic tract. In the spinothalamic tract, usually the sacral fibers are lateral or outside, and the cervical fibers are to the medial. So when the fibers of the spinothalamic tract comes into the spinal cord and crosses to the opposite side, they are arranged in a way that the lower fibers are coming from the lower limbs, for example, are lateral in the tract itself. And the upper fibers are coming from the thoracic or the cervical part. Usually they are medial. Why this information is important? Because when we talk about tumors coming from the meninges of the spinal cord, extramedullary tumors, usually they are going to breast the spinal cord from outside. They are going to damage the spinal cord from outside, and that means which fibers will be damaged? The sacral fibers will be damaged. So in the history, if there is case scenario, for example, a problem, they will mention that the pain is lost sensation in the lower limb and the sacral area or the buttock area, and then after that he started to lose sensation in the upper limb. So if the patient is losing sensation from the lower limb before the upper limb, that means the tumor is coming from outside the spinal cord, extramedullary tumor. If the patient is starting to lose sensation in the upper limb, then after that in the lower limb, that means the tumor is intramedullary. It is coming from inside the spinal cord, resting on this area. This is actually when you come across one case scenario in the questions you are going to revise, then you will understand it. But as a general, because we don't have a question like this in our training today, if there is a tumor coming from outside, extramedullary tumor, the patient will complain of loss of sensation in the lower limb before the upper limb. It is extramedullary. If he is complaining from loss of sensation in the upper limb before the lower limb, then okay, this will be intramedullary tumor. Okay, this is another information. Lastly, before starting the questions, actually, we are going to talk about the sensory cortex. The sensory cortex is found in the both central gyrus. In the both central gyrus, there is the sensory cortex, the primary sensory area. There is another secondary sensory area in the wall of the sylvian fissure, not important. This is the most important. It will carry it will receive sensation from the contralateral side of the body. Usually the size is proportional to the density of receptor, and the body is represented upside down. These are the most important features. Body is represented upside down. That means the lower limb are represented up, and the upper limb and the face is represented down. Okay, if there is damage in the upper part of the cerebral cortex, the lower limb will be affected. If there is damage into the lower part, that means the upper part of the body will be affected. The second thing, the size of representation is proportional to the density of receptor. So, for example, the thumb and the hand and the lips and the tongue, usually the size in the sensory cortex are very large, but the size of the lower limb and the back is very small. So these are minor information you have to know about the sensory tract, and it is the most central gyrus, as you know, and the most important also is the coding of sensory information. Usually there are many questions about coding of sensory information. So what do we mean by coding of sensory information? It is the code by which the brain can discriminate the locality, the modality, the intensity, and the duration of sensation. Because the brain will receive the impulses in form of action potential. Action potential will reach the brain, the cerebral cortex, but the cerebral cortex can discriminate which modality of sensation is this action potential. Although touch will reach the brain as action potential and pain will reach the brain as action potential, the brain can discriminate, is that touch or pain? So there is a special code. We are going to talk about how can the brain discriminate between the different types of sensation. Type of sensation is the modality, and from where the sensation is coming, this is the locality, and whether the sensation is mild, moderate, or very hard sensation, very hard touch, or very hard pain, very severe pain. This is known as the intensity of sensation, and the duration, whether short duration or long duration. So what's the code? We'll start with the modality of the sensation. The modality of sensation, usually the brain can discriminate between different types of sensation by doctrine of specific nerve energies. What is doctrine of specific nerve energies? Let me explain first. Action potential is coming from the receptor. Then it will go through the afferent neuron. Okay? Remember, there is a nerve, and within that nerve there are thousands of neurons. So there is a special receptor, and a special neuron within that nerve is carrying that type of sensation. And in the tract, also a special neuron in the tract is carrying that sensation, and a special area in the cortex. So pain is going from certain receptor through certain neuron, afferent neuron, through certain tract to certain area in the cortex. Touch is coming from different receptor, through different neuron, through different another neuron in the spinal cord, through different area in the in the brain, in the cerebral cortex. So for each modality of sensation, there is a special receptor and a special tract or a special course, afferent and tract. Okay? So if you are stimulating the receptor itself, when the action potential reaches the brain is going to discriminate this by referring it to the adequate stimulus of that receptor. So the brain will know that this action potential is coming from that receptor in the big toe. And that receptor is for pain. So it gives the sensation of pain. If the sensation is touch, that means another receptor is stimulated, another afferent neurons, another area within the same cerebral cortex will be stimulated. So the brain will know that it is from that receptor for touch, I will give the sensation of touch. Okay? This is known as doctrine of specific nerve energies. Okay? When the action potentials of one sensory pathway reaches the cerebral cortex, the sensation perceived is that to which the receptor is specialized for. okay, to which the receptor. So the brain is going to refer to the receptor and to the adequate of stimulus to which the receptor is specialized for specific doctrine of specific nerve energies. That's for the modality. The locality is almost similar because the brain is going to refer or to discriminate the locality, the site of stimulation, by referring to the site of the receptor itself. For example, if the stimulation in the receptor of the big toe, when the action potential reaches the brain is going to give the sensation that it is coming from the big toe. If you are stimulating the same tract in the cerebral cortex itself or in the spinal cord, when the action potential reaches the cerebral cortex, also it will refer it to the big toe because the receptor is found there. So wherever you are going to stimulate, when the action potential reaches the brain, usually it will refer to the receptor, or it will give the location to the receptor. Okay, and that what by this we can explain the phantom limb. You know the phantom limb. I think already most probably during the lecture they describe that for you. Phantom limb الرجل الشبح. يعني if there is a diabetic man, he has an amputation of the right lower limb, okay, below the knee. So he has no leg. This patient has no right leg, but he is complaining of pain in the big toe of the right leg. So the doctor will say that there is no right leg even, and there is no big toe, but the patient will say that I have pain in the big toe, and there is no big toe. This is known as the phantom limb. And the explanation is that usually at the area of the stump, the lower area of the limb, where there is the end of his lower limb and the amputated part is there, usually the neurons there, the endings of the neurons may fire spontaneously. May spontaneously fire action potential, or maybe the tissues there are pressing on the nerve and the nerve is stimulated. So the action potential from the knee, starting from the knee, will go until it reaches the brain. And the brain is going to refer to the receptor in the big toe, not to the knee, to the receptor in the big toe. So that's why the patient is having pain in the big toe. This is known as law of projection. Okay, law of projection. So the brain will project the locality to the site of the receptor. Again, modality by doctrine of specific nerve energies, and locality is explained by the law of projection. And definitely intensity is very easy because when you, for example, touch the lower limb, you are going to stimulate 10 receptors. When you, for example, make hard touch, you are going to stimulate 20 receptors. So by increasing the number of receptors stimulated, the sensation will be hard touch. So the intensity will differ according to the number of receptors stimulated. Also to the number of frequency of action potential generated. So if the frequency of action potential is increased, this is also going to give sensation of higher intensity. So again, intensity by number of receptors stimulated and frequency of action potential generated at the site of stimulation. And the duration definitely by the onset and the end. If you are going to touch the lower limb, for example, when you start touch and when you end, the impulses will reach the brain and then will stop, then the brain will give the duration accordingly. So that's the coding of sensory information. By coding of sensory information, we finished talking about the sensory system. There is a special information about pain. Okay, we can cover very quickly. Pain, as you know, has two qualities. First quality known as pricking pain, and second quality known as burning pain. Okay, or first pain and second pain, like that. So pricking pain, usually first pain, it is transmitted through A delta because they are rapidly conducting. And burning pain is through type C. And I think it is better for you if you remember, if you have pain in your hand or in your finger, if there is any pain in your finger, this pain, actually two types of pain. Immediately after the trauma, there is pain, sharp pain, and after a while, there is throbbing or burning pain. The sharp pain at the beginning is known as the first pain or pricking pain. And the second pain coming after that is known as the burning pain or the second pain. The first one will go through A delta, and the second one will go through type C. That's why the first pain is rapidly perceived, and the second pain is perceived after a while, because C are slowly conducting fibers. You know, the conduction velocity of C is only about 1 meter per second, only 1 meter per second, while type C 30 meter per type A delta, I mean 30 meter per second. So there is a big difference between them. That's the first pain, and this is the second pain. So these are the two qualities of pain. This is one information. Pain receptors are free nerve ending, not specialized, and afferent, as I mentioned, the afferent neurons are two types, A delta and C. A delta for the first and C for the second pain. And the tract is the spinothalamic tract. What is the other name of the spinothalamic tract? Anyone can answer me? This is the other name of the spinothalamic tract.
Anterolateral tract.
Very good, excellent. Anterolateral tract. So the anterior part is mainly for touch, and the lateral part for pain and temperature. So again, if you remember touch is also carried through dorsal column tract. Fine touch through dorsal column tract. Crude touch through anterior part of the anterolateral tract. So for you, so you will never forget that in the future. Touch is carried anteriorly and posteriorly in the spinal cord. In the anterolateral tract, okay, anterolateral tract, the anterior part, in the dorsal column tract. Okay, but as you know, crude touch is in the anterior part and fine touch in the posterior part. Again, touch is carried anteriorly and posteriorly. Pain is carried laterally. Okay, so again, anterolateral tract or spinothalamic tract, the anterior part for crude touch and the lateral part for pain sensation. And in the sensory cortex, as you know, what is the function of the sensory cortex? The sensory cortex can discriminate modality, locality, intensity, and duration, as you know. For pain, usually the modality of pain is known when it reaches the cortex. They found that usually the modality of pain is already known when the impulses reach the cortex. That means discrimination of pain, unlike the other types of sensation, discrimination of pain occurs at or below the level of the thalamus. So below the thalamus, usually pain is already known. And this is protective actually, because before reaching the brain, usually there is awareness that there is pain. So the brain will be prepared so as to react to that and to give us, the appropriate action against that as a protection. So remember, below or at the level of the thalamus, usually, that's why thalamectomy, usually when we remove the thalamus, we can treat pain. In some patients, usually, if pain cannot be controlled by medicine or by surgery, then the only way to actually to treat this patient is to remove the thalamus, because you know the thalamus is the sensory station of the body. Thalamus is the sensory station. All types of sensation should go through the thalamus. Spinothalamic tract. That means touch, temperature, position, crude touch, pain and temperature, itching, sexual sensation. All of them should go to the spinothalamic tract. So they should reach the thalamus. And dorsal column tract, fine touch, position, two-point discrimination, pressure, vibration, all these also will go through the dorsal column tract to reach the medulla. From the medulla, they will cross to the opposite side and ascend to reach the thalamus also. So all types of sensation should reach the thalamus, except olfaction, as you know, especially except the sense of smell, the only sensation that never reaches the thalamus. So thalamectomy can treat pain, and frontal lobe removal also can treat pain, because also the emotional reaction to pain is determined by the frontal lobe. So removal of the frontal lobe will remove the emotional reaction to pain, and the patient will become indifferent to pain. There is pain, he knows there is pain, but he's not reacting to that pain. And salamectomy, the sensation of pain is completely removed. Anyway, as I mentioned, the cortex should know the locality, the intensity, the duration, and the modality, the locality, the intensity, and the duration. But for pain, it will know only the locality, the intensity, and the duration. Modality is already known at or even below the thalamus. That's what I wanted to mention. Last point is, so before the last actually, we have cutaneous pain whenever the receptors are found in the skin, and we have somatic pain and visceral pain. When the receptors are found in the muscle or bone, it is known as somatic. When the receptors are found in the viscera, it is known as visceral pain. Okay. The pain differs from somatic and visceral. Why it differs is very important actually. Pain in the skin has two qualities, first and second. In the somatic and visceral, it is only second. It is only burning pain. There is no pricking pain. That's one. Okay. And the second thing, usually pain from the skin is carried through A delta and C. That's why it has two qualities. But in deep somatic and visceral, it is carried mainly through C. That's why it is only burning pain. Second. Third difference, usually pain in the skin is not associated with autonomic stimulation. There is no vomiting, there is no sweating, but somatic and visceral pain, there is vomiting and there is sweating. If there is appendicitis, the patient may vomit. If there is fracture, the patient may vomit, okay, and there is sweating in the face, indicating that there is somatic or visceral pain. And there is no contraction of nearby muscle. If there is fracture, the nearby muscles will contract to fix the fracture. And if there is, for example, appendicitis, the abdominal muscles will contract to protect the appendix from any contact from outside, so as not to irritate and to result in rupture of the viscera. This is not as guarding, so to guard the internal structure from the external stimuli. So when the doctor tries to palpate for the appendix, usually he will find guarding, which indicates there is inflammation inside and pain from inside. So contraction of nearby muscle is found in somatic and visceral pain. It is not found in cutaneous pain. These are the main features of the cutaneous, visceral, and deep somatic pain. Deep somatic and visceral together, and cutaneous is different from them. Last but not least, central inhibition of pain. I think you know about it. Central inhibition of pain, that means the ignorance of pain. For example, during stress, there is ignorance of pain. During football, for example, match, there may be trauma, but the player will not be aware of that injury. He will feel the pain after the match. That means there is ignorance of pain during the match, during the stress. Okay, so also if you are rubbing, for example, if there is any pain in the lower limb and you are rubbing, scratching this area, by the scratch usually this pain will decrease, so or will disappear. So this scratching will result in inhibition of pain. How? By central inhibition of pain. Central inhibition of pain is explained by, for example, convergence theory and facilitation theory, and usually okay, we have to also talk about referred pain. Okay, so I will complete my talk about convergence and facilitation theory. Then lastly, I will talk about, but I need the information of referred pain. Let me talk about referred pain first. For referral of pain, usually, which is a feature of deep somatic and visceral pain, and it is not a feature of cutaneous pain, referral of pain. Pain from the skin is not referred to anywhere, but pain from the muscle or from the viscera can be referred to other structure. For example, pain from the heart is received as the skin of the inner arm. Pain from the liver will result in the irritation of the diaphragm, and this will result in pain in the tip of the right shoulder. So it is referred to the tip of the right shoulder. That means referral of pain. As explanation of the referral of pain is that usually pain is referred to the structure, to the skin usually, that coming from the same dermatome of that structure. In other words, just for we have dermatomes in the embryo. The dermatomes consist of skin, derma, and muscle. That's why it is known as dermatome. The muscle usually, for example, muscle of the heart will go to its original site, but the skin will go to another area. For example, the skin of the inner arm. So skin of the inner arm and the muscle of the heart, they come from the same dermatome. Okay, they come from the same dermatome, and because of they are coming from the same dermatome, usually the second order neuron may be common for them. That means we have first order neuron coming from the skin and first order neuron coming from the heart. Both of them will converge on the second order neuron in the spinal cord. Okay, that's why there is convergence here, convergence theory. And facilitation theory is another theory also to explain referral of pain. But also it depends on the dermatomal rule. That means the skin and the viscera. The first order neuron, they are going to converge, but not on the same second order neuron, on different second order neurons. But there is facilitation from that of the viscera to that of the skin. So unfortunately there is no here any photos for you to understand it, but I hope you can see it in the book. Yes, I think it is here. Yes, okay. The photo is here in front of us. Look at the convergent theory. Convergent theory explains the mechanism of referred pain. As you can see, the viscera will give first order neuron, and the skin will give first order neuron. Both of them will converge on the same second order neuron. Okay, they converge on the same second order neuron because of the dermatomal rule, because the viscera and the skin, they came from the same dermatome. The impulses will reach the brain. The brain is used to impulses coming from the skin. Every day the skin is sending impulses to the brain. For example, the skin is stimulated by the external environment, by the shirt. For example, when you wear the shirt by any touch from outside, skin is repeatedly stimulated, and the impulses repeatedly reach the brain. And the brain is used to refer or to project the stimulation to the site of the receptor in the skin. So the brain now knows that whenever there is impulses reaching it through that pathway, it comes or they come from the skin. One day, the viscera become inflamed, and the viscera now is sending impulses through the same pathway to the brain. But the brain is used to refer the impulses to the skin, so it will continue referring the impulses to the skin. So we will say that although the inflammation is found in the heart, but the patient is feeling the pain in the skin of the inner arm, because the brain is used to receive the impulses from the skin of the inner arm. If the heart is sending impulses now, that does not mean that the brain is going to project to the heart. It will project again to the skin, as it usually do. So yes, as it usually does. So as I mentioned, this is the convergent theory, and that's the explanation. I hope it is clear. For the facilitation theory, it is similar. The skin and the viscera from the same dermatome, they converge on the same segment, but on different second order neuron. But as you can see, that of the viscous, the first order neuron, will give collateral, will give branch to that of the skin. Okay, there is a branch coming to that of the skin. Now the second order neuron of the skin is receiving impulses from two sources. Receiving impulses from the skin and receiving impulses from the viscous. And actually the explanation is that the skin usually sends subthreshold stimuli to the second order neuron. These stimuli are not reaching the brain because they are not reaching the threshold. Now our skin in any area is sending.
I think we have lost Prof. Tarig. We'll just wait for it again. Prof. Tarig? Can you hear me? Prof. Tarig؟ لحظة بس اتصل عليك. على بال ما يرجع لنا بروف طارق فاهمين كويس يعني متابعين المحاضرة؟
فاهمينها يا دكتور.
لو عندكم أي أسئلة خلوها جاهزة للبروف.
Okay.
معلش لحظة بس أنا بتصل عليه. طيب أنا أفتكر إنه هو غطى كل باقي لكم بس الجيت ثيوري و يتكلم عن السنترال انهيبيشن وهي تاتش اون ذا تاتش. باقي التمبريتشر. طيب رايك نشرد ننتظر شوية ولا نختم المحاضرة دي ونخلي الجزء الثاني في محاضرة ثانية. الساعة كم عندكم؟ الوقت متأخر، شغالين بكرة صح؟
شغالين على لكن ما عندنا مشكلة.
شغالين بكره.
طيب خلاص we'll give him 3 minutes. إذا ما جاء we will conclude this lecture and he will continue from wherever he stopped next time إن شاء الله.
بس شافوا يا دكتور في الجروب قال 5 minutes وحيكون معنا عنده مشكلة في الشارجنج بروبلمز.
ممكن إذا قال كده في الجروب كويس ممتاز. طيب ممكن نعمل break for 5 minutes. The room is open. Whoever wants to هو بيكتب لي دلوقتي لحظة بس. قال 5 دقائق صحيح. طيب لحظة بس أرد عليه. طيب هو اقترح انه نبدا في الاسئله، لكن انا افتكر انه نعمل بريك. اللي عايز يشرب مويه ولا عايز ممكن تكون داخل الجروب وممكن تطلع وترجع تاني. We will break for 5 minutes. الساعه عندكم دلوقتي 8 و10 هنرجع 8 وربع. اوكي
اوكي يا دكتور عمار.
ايوه، اللي عايز يكون موجود في الغرفه ممكن يكون موجود، واللي عايز يطلع ممكن يطلع ويرجع تاني. انت لما تكون عامل ميوت زي كانك مش موجود، يعني ما فيش مشكله.
For the facilitation theory, can you bring the photo again? Facilitation theory. Yes, so facilitation theory. The theory, the picture. Yes, this one. Okay. So as you can see, first order neuron coming from the viscous, and first order neuron coming from the skin, and there is collateral or branch from that of the viscous to the skin. Now the second order neuron from that of the skin is receiving impulses from two sources, from the skin and from the viscous. And usually those impulses coming from the skin are subthreshold. They cannot excite the second order neuron. So the brain is not receiving impulses from the skin. This is the second theory actually, because it is just postulated theories, not necessarily to be right. And as you can see, the brain is not receiving impulses from either from the viscous or from the skin. And usually, as you know, the receptors in the viscera is very few. And the adequate to excite the second order neuron, their second order neuron, or through the branch, the second order neuron that of the skin. But the second order neuron of that of the skin is receiving impulses from two sources: inadequate impulses from the skin itself and inadequate impulses from the viscera after its inflammation. So after inflammation of the viscera, some impulses will come through the branch to the second order neuron of that of the skin. Now the threshold is reached, and the impulses are going through the second order neuron of that of the skin to reach the brain, and the brain is going to project to the skin, because the second order neuron of the skin is excited, not the second order neuron of that of the viscera. This is that's a second theory to explain referred pain. So referred pain can be explained by either the convergence theory or the facilitation theory. Both of them depend on the dermatomal rule. That's the skin and the viscera, they come from the same dermatome during embryonic development. That's about referred pain. For central inhibition of pain, actually it is explained by other, not by convergence or facilitation theory. It is explained by other theories, by gate control theory and by central inhibition of pain. In gate control theory, we started to talk about it. We mentioned that substantia gelatinosa is the gate for pain, and this gate will open for A beta fibers and will close, will open for type C and will close by A beta fibers. So if there is, for example, pain coming from type C fibers, usually the impulses will come and will reach the substantia gelatinosa, second order neuron is starting here, and then it will excite the second order neuron and the pain is perceived. But if you are scratching or rubbing that area around the pain area, usually you are going to excite A beta fibers through touch sensation. A beta fibers are going to close the gate, and that's why the pain will disappear, because the gate is closed by stimulation of A beta fibers. That's the gate control theory. Central inhibition of pain depends on release of endorphin and enkephalin, usually during stress, because during stress the stress hormones are released, mainly the ACTH and cortisol. And ACTH, adrenocorticotropic hormone, will come from large precursor molecule known as pro-melanocortin. Pro-opiomelanocortin, as you can see from the name, pro-opiomelanocortin. Cortin will give ACTH, and opio will give opioid, which is endorphin, beta endorphin. And beta endorphin is capable of stimulating the receptors like the receptors that respond to morphine. And they are going to inhibit pain by stimulating the pain-relieving receptors. So this is the central inhibition of pain. Stress usually will stimulate these types of chemicals to stimulate the receptor and to relieve pain. That's central inhibition of pain. And this will explain why during games usually pain is not perceived, because of the release of the stress hormones associated with them, the beta endorphin, which is released, and it is going to relieve pain. So this is very quick overview of the sensory system. Sorry for going very quickly like that, because the time is not helping. And now we very quickly now go through the questions. I will go immediately through question number 1. I hope at least 1 or 2 students will help me. When I ask the questions, they will start to mention whether true or false. Not necessarily the correct answer, just true or false, and not necessarily to be correct or incorrect, because explanation will come. Question number 1, the receptor potential is propagated. True or false?
معذرة دكتور طارق. دكتور طارق، الاتندنس ممتاز، لكن عندنا مشكلة في الانتراكشن. فأنا أقترح إنه الطلبة موجودين، كل الطلبة لازم يشاركوا في الأسئلة. أنا حساعدك يا دكتور طارق لو ما عندك مانع بإنه I will pick up a student، لأنه هم they don't volunteer for each question. It doesn't matter if he answers wrong, لكن you have to participate.
Just to say true or false. When you mention the name, for example, he will say true or false like that. So not necessarily to be correct. Yes.
طيب عثمان أحمد.
نعم.
Okay, your question number 1. تفضل يا بروف.
The first one is false.
The receptor potential, if you remember, Usman, there is difference between receptor and action potential. Receptor potential, action potential. We mentioned 4 differences. Receptor potential is local, action potential propagated, receptor potential is graded, action potential is all or none, and receptor potential, you remember, receptor potential, these are the, by subspiritual stimuli, action potential by spiritual. So these are the main difference between the receptor potential and action potential. Now we are talking about the receptor potential. Is it propagated?
False.
Yes, this is the action potential. Is it all or none?
False.
This is the action potential. Very good. Is it perceived as light sensation?
لا.
Perceived as light sensation, that means it will reach the cortex and the cortex will give the sensation. So is it going to be perceived as light sensation?
لا. False.
Yes, because it will never excite, will never be transmitted through the cortex, will never be transmitted to reach the cortex. Is it related to the intensity of stimulation?
Aye.
Yes, definitely. Yes, because the receptor potential will increase and decrease. It is graded according to the intensity. This is the correct answer. Very good. And only generated in encapsulated receptors. It will be false because it can be generated in free nerve ending, in encapsulated, in sense organs, anyone. Excellent. Thank you. Any other student?
Second question, أنا حمشي بالأوردر. هم they will take time to volunteer. أحمد عثمان, unmute yourself please.
طيب أحمد, concerning pain sensation, احنا اتكلمنا عن البين، ولو بتتذكر قلنا البين الريسبتور بتاعته فري نيرف اندنج وبيمشي عن طريق تايب سي واي دلتا مع بعض. تايب سي بتدي السكند بين، وتايب اي دلتا بتدي الفيرست بين. وقلنا التراكت هو السباينوثالاميك تراكت مين اللاترال بارت. وقلنا مش كده الكورتكس بيعرف الموديل الانتنسيتي والديوريشن واللوكاليتي. الانتنسيتي اوريدي بتكون معروفه لانها بتتعرف at the level of the thalamus or even below the thalamus. ده الكلام اللي احنا قلناه. طيب يلا نمشي واحده واحده. concerning pain sensation, it is transmitted through the dorsal column tract.
أحمد has not unmuted himself. عايزين آلاء and أروى. Both of you will answer these questions. آلاء وأروى.
if they are feeling stress يا عمار ممكن نخلي واحد
to volunteer.
يعني
تفضل.
some students are reluctant to answer so في بعض students can volunteer they are very يعني نخليها voluntary يا عمار.
يا
تفضل.
دكتور.
طيب تفضل.
anyone.
يا دكتور.
Yes, okay. So I will continue with you only you, okay?
معك تجاني أفتكر. أيوة تجاني نعم.
Tijani, I will continue with you only you يا Tijani. Just answer, okay? I will not ask any
Okay.
other student, okay? طيب Tijani, you are with me? Now we are talking about pain sensation. Again, I will repeat the most important information about pain. Pain receptors بتكون في nerve ending بيمشي بالسباينوثالاميك تراكت mainly باللاترال بارت اوكي وقلنا الكورتكس بيعرف اللوكاليتي والانتنسيتي والديوريشن ما محتاج يعرف الموداليتي because the modality is known at the level of the thalamus or even below the thalamus اوكي معاي تجاني؟
معاك.
طيب it is transmitted through dorsal column tract.
لا spinothalamic.
Spinothalamic tract, very good. Receptors are encapsulated.
لا free nerve endings.
Receptors are free nerve ending, excellent. Slow pain is transmitted through C.
Slow pain is transmitted through CI.
Excellent, yes. والA delta ذاك الفاست بين بيمشي بالA delta والC بيمشي للسلو بين يبقى دي الكوريكت انسر. كذلك نشوف احتمال يكون في another answer. Modality discrimination occurs at the sensory cortex.
لا هسه قلنا at the thalamus
The thalamus or below the thalamus, very good. Localization occurs at the level of the thalamus.
لا قلنا modality بس.
Localization بيحصل في السيريبرال كورتكس. تمام ممتاز. طيب يا تيجاني نمشي للسؤال الثاني. The dorsal column tract. تتذكر السنسيشنز في الدورسال column tract ممكن تقولها لي؟
الدورسال column tract في fine touch و pressure.
Vibration.
و
position sense و 2 point discrimination. تمام؟ يلا هو dorsal column tract is carried through عندك الاوبشنز موجودة. which of them؟
Steve vibration sense.
Excellent, vibration. This is the correct answer. نمشي لللوكاليزيشن of a touch sensation is a function of. لو بتتذكر اللوكاليزيشن قلنا اللوكاليزيشن هو الفانكشن بتاع which of them. كده شوف الاوبشنز دي واديني الانسر حسب الكلام اللي احنا قلناه.
Localization قلنا the sensory cortex.
Excellent. السنسوري كورتكس قلنا السنسوري كورتكس ما بيعرف اللوكاليتي اونلي بيعرف اللوكاليتي و مش كده؟ ما عدا البين طبعا ممكن تعرف قبل اكسلنت التجاني. نمشي للسؤال اللي بعده. البين اذا كاركترستيك قلنا الفيزرال بين بيختلف من الكيوتينيوس بين. الفيزرال بين والسوماتيك بين نمره واحد قلنا الريسبتورز بتكون في السكين في الكيوتينيوس. الفيزرال ريسبتورز بتكون موجوده في دائما في الفيزرال في الكيوتينيوس بيكون في تو كواليتيز فاست بين وسلو بين. في الفيزرال بيكون كواليتي واحده وقلنا دائما بيكون في الكيوتينيوس بين it is not associated with autonomic stimulation. It is not associated with contraction of nearby muscle and it is not referred. اما العكس طوالي بيحصل في الفيزرال بين. فنشوف الاسئله دي تجاني. its receptors are free nerve sorry وين احنا؟ Yes. Its receptors are free nerve ending. Yes.
لكن ما
السؤال عن accept. اوكي سوري السؤال accept يبقى receptors are free nerve ending correct مش كده؟
الا واحد
correct وبالتالي يعني يبقى دي ما الإجابة المطلوبة because السؤال هو محبوس accept. طيب. local yes يبقى receptors are free nerve ending yes but this is not the correct answer. Its localization is a function of the cerebral cortex.
من modality but not
طيب
the cerebral cortex.
usually function of the cerebral cortex except for visceral pain يا تجاني. اوكي يعني هنا except for pain يعني pain اللوكاليزيشن sorry yes localization is a function of the cerebral cortex. This is the correct answer because it is not correct مش كده؟ اللوكاليزيشن هو في السيربرال كورتكس. This is correct. Okay. So it is not the correct answer. معلش except دائما بتعمل لخبطة في الموضوع. Yes, cerebral cortex can discriminate locality. يبقى it is correct, but it is not the correct answer. It is associated with autonomic activation.
قلنا sweating و vomiting و
It is
tachycardia.
correct, but it is not the correct answer. مش كده؟ Visceral pain لأنه إحنا بنتكلم عن except. يبقى it is correct, but not the correct answer. تمام. It is associated with contraction of nearby muscle.
صح اللي هي the spasm of the whole line.
Not the correct answer. Yes, you are right. تمام. And it is referred to another visceral structure.
يلا دي غلط.
Yes, it is referred not to other visceral structure, referred to the skin, not to other visceral structure, to the skin. Okay? يبقى بالتالي لأنه قال visceral structure, this is incorrect. وبالتالي دي تكون الإجابة الصحيحة. نمشي للسؤال نمرة 6. The intensity. لو في student تاني عايز يشارك ويساعد التجاني ممكن. لو التجاني عايز يواصل خلاص. The intensity of stimulus is determined by. احنا قلنا الانتنسيتي اوف ستيمولس في 2 فاكتورز بتحدد الانتنسيتي. number of receptors generated, frequency of action potential, number of receptors stimulated, frequency of action potential generated. Okay, these are the 2 factors that determine the intensity. وبالتالي الكويشن straightforward. الإجابة حتكون شنو؟
frequency of action potential.
Yes, number D, frequency of action potential. ممتاز. نمشي للسؤال نمرة 7. Regarding adaptation of receptors. قلنا receptors can be rapidly adapting ودي زي التاتش و can be intermediately adapting like a temperature و can be non-adapting like a pain وهكذا. فالسؤال هنا مختلف شوية. قال لك regarding adaptation of receptors. They depend on type of adequate stimulus. True or false؟ ما عنده علاقة. adequate stimulus ما بيحدد الادابتيشن، ما عنده علاقة بالادابتيشن. occurs at the same rate of different receptors.
غلط. false.
Some receptors will adapt rapidly and some receptors will adapt slowly, so it is not the same rate. It is due to release of inhibitory neurotransmitter.
برضه false.
false. ما في neurotransmitter released في الريسبتور. It is due to inactivation of ion channels. Possible.
أظن.
Possible. So it is due to activation of ion channels. Possible. نشوف الأخيرة عشان نتأكد إنه دي correct answer. Never occurs in free nerve ending. Never is never correct. Okay. Never is never correct. Okay. Take it as a. So usually the answer will be number D. Okay. Always wrong and never correct like that. Usually في بعض القواعد اللي ممكن تاخدوها في الانستيتيوت. يبقى although free nerve ending for pain it is non-adapting, لكن for temperature it is free nerve ending and it is intermediately adapting receptor. So never correct. نمشي للسنسوري اتاكسيا. السنسوري اتاكسيا usually انا ما كلمتكم عنه. Usually the patient will stand upright and will close his eyes. وطبعا لانه طبعا يعني هي بتعتمد على البوزيشن سنس اللي بيسموه البروبريوسبشن، بيمشي بالدورسال كولم تراك. لما يكون في مشكله في البروبريوسبشن في الدورسال كولم تراك the patient will maintain position by vision. بيكون بالنظر بتاعه عارف البوزيشن وعارف الموقع بتاعه، فبيكون standing upright. فلو قفل عيونه when he closes his eyes فبيكون فقد الكومبنسيشن الحاصل فبيحصل له كولابس. فبالتالي السنسوري اتاكسيا will occur in patients with damage to the dorsal column tract وبالتالي they will lose the position sense, they compensate with vision. When they close their eyes they will collapse immediately, they will fall down because of the loss of the dorsal column tract. يبقى في السنسوري اتاكسيا احنا بنسموها طبعا رومبيرج ساين، فبتكون رومبيرج ساين بوزيتيف لو كان في البيشنت كولابس after closing his eyes. فنشوف الأسئلة عن السنسوري اتاكسيا. It results from damage to the spinothalamic tract.
لا هسه قلنا الدورسال.
dorsal column tract. Yes. Associated with negative Romberg sign.
لا هسه قلنا positive Romberg sign.
Positive Romberg sign. Is characterized by loss of proprioceptive sensation.
قلنا البوزيشن سنس
ده
اللي
البوزيشن
فيها
سنس.
مشكلة.
ممتاز. It causes is a cause of drunken man gait.
لا.
drunken man gait ده هندرسه في الموتور سيستم. ده الجيت اللي بيحصل في السيريبيلر دامج. لما يحصل سيريبيلر اتاكسيا بيكون البيشنت عنده drunken man gait. ده في السيريبيلر اتاكسيا ما في السنسوري اتاكسيا. It causes coma when a patient closes his eyes.
No.
ايوه تمام. بيحصل كولاس ما بيحصل كوما. تمام. Which of the following receptors are phasic؟ ده direct question.
دكتور دكتور
Yes. ايوه.
يعني في فرق بين cerebellar sensory ataxia.
سيريبيلر اتاكسيا وسنسوري اتاكسيا فرق كبير. السنسوري اتاكسيا دي للدورسال كولم تراك للوس اوف بوزيشن سنس. سيريبيلر اتاكسيا للسيريبيلم في الموتور سيستم. سنسيشن ما في مشكله. في مشكله بس في السيريبيلم لانه مسؤول عن البالانس. فالبيشنت بيكون عنده درانكن مان جيت. بعدين الرومبيرج ساين بتفرق بيناتهم. يعني الرومبيرج ساين دي بتكون بوزيتيف في حاله السنسوري اتاكسيا البيشنت بيجي واقع. لكن في حاله السيريبيلر اتاكسيا ما بيجي واقع البيشنت. لكن المشي بتاعه هو اللي انستدي جيت. فنمشي للسؤال نمرة 9. which of the following receptors are phasic؟ ده دايركت كويشن التجاني.
phasic قلنا rapidly adapting فهتكون ايه touch receptors.
touch receptors بالضبط. touch receptors. طيب hemisection of the right side هذا داير شوية كده. تتذكر احنا قلنا في الهيميسكشن of the spinal cord. كده انا بديك شوية أسئلة اتذكر اشوفك متذكر ولا لا. لما يحصل هيميسكشن في السباينال كورد في الرايت سايد بفقد شنو في الرايت سايد وبفقد شنو في الليفت سايد؟
في الرايت سايد بنفقد الدورسال كولوم تراكت
ممتاز.
والسباينال ثالث
يعني
ما
الفاين
بتكون.
تاتش والبوزيشن والتو بوينت ديسكريميشن ولا يس وفي السباين وفي الليفت سايد بفقد السباين سلاميك تراكت اللي هو البين والتمبريتشر مش كده؟ تمام. نبدا نشوف السؤال. Hemisection of the right side of the spinal cord. Loss of pain in the right side.
لا قلنا pain spinothalamic.
في الليفت. Loss of temperature sense on the same side.
برضو غلط.
يعني الرايت سايد برضه. التمبريتشر البين والتمبريتشر مع بعض في السباينوثالاميك صح؟ يبقى هتكون false. Loss of vibration on the opposite side.
لا قلنا الدورسال column is the same side.
المفروض يكون في الرايت سايد same side. Yes. Intact touch on the same side.
Intact touch.
Yes.
um,
طبعا انا بفقد الدورسال كولم. الدورسال كولم فيه شنو؟ فيه الفاين تاتش والبوزيشن سنس والتو بوينت ديسكريميشن مش كده؟ يبقى انتاكت تاتش. لا ما قلنا بفقد الدورسال كولم صح؟ اون ذا سيم سايد. اللي هو الدورسال كولم فيه الفاين تاتش. يس يبقى غلط. تمام. loss of position sense on the right side.
position sense اللي هي dorsal column فصح.
dorsal column. في الرايت سايد كوريكت انسر. تمام ممتاز. دي الاجابه الصحيحه. ممتاز جدا. طيب which of the following neurons has the highest conduction velocity؟ لو بتتذكر قلنا نيورونز A B C و A الفا و A بيتا و A جاما و A دلتا واسرع واحده فيهم
اسرع واحده A الفا. طيب A الفا.
A الفا exactly. تمام. نمشي للفيرست بين. الفيرست بين لو بتتذكر نفس المعلومات اللي قلناها. receptors are Basinian corpuscles للبين.
غلط.
ايوه باسينيان دي دائما للتاتش وممكن للترانزيانت بريشر. البريشر اللي ما بكون كونتينيوس الفيري شورت لايف بريشر يعني لايت بريشر. لكن مينلي للتاتش دي الباسينيان كوربسلز. طيب is carried by type C؟
type C لا قلنا ده السلو بين.
ده السلو بين. ممتاز. is transmitted in the lateral part of the spinothalamic tract؟
صح.
ممتاز ممتاز. is usually visceral؟
لا visceral قلنا slow pain. visceral وسوماتيك.
ممتاز. يبقى دائما الفيرست بين بيكون مع الكويتينيوس بين. تمام. is a burning sensation؟
غلط. قلنا first pain is the breaking.
second pain. الفيرست بين دائما بيكون breaking pricking sensation.
أي.
يبقى هي الأسئلة دي straight forward وما يعني بتتكرر، يعني ما في أسئلة غير كده، يعني إذا كنت عارفة المعلومات دي خلاص كده تكون عارفة السنسوري سيستم. طيب concerning the deep somatic pain which of the following is not true؟ الديب somatic زيه زي الفيزيرال لو بتتذكر، بيختلف من الكيوتينيوس ونفس الاختلافات اللي احنا ذكرناها، فنشوف مذكرة ولا لا. associated with sweating and vomiting.
قلنا دي الأوتونوميك ستيميوليشن
يس
صح.
موجودات في السوماتيك وموجودات في الفيزيرال. احنا سؤالنا نوت ترو، نوت ترو يعني احنا دايرين الغلط. ف سويتنج اند فوميتنج ترو، لكن ما الإجابة الصحيحة. تمام، لأنه احنا عايزين اكسبت. associated with contraction of nearby muscle.
أيوة قلنا الجاردنج زي الجاردنج.
ممتاز، الجاردنج ممتاز، very good. is well localized.
ده غلط، ده first pain.
دي
احنا
غلط،
قلنا
يبقى دي
الديب
الإجابة الصحيحة لأننا دايرين الإجابة دي. فويل لوكالايز ده الكيوتينيوس ما الديب سوماتيك. اسكريت ثرو تايب سي.
صح لكن ما الإجابة الدارينة.
صح لكن ما الإجابة. كان بي ريفيرد.
صح برضو لكن ما الإجابة الدارينة.
صح لكن ما الإجابة. ممتاز ممتاز اتجاه. which of the following receptors is non-adaptive؟ ده برضو هنا هدية أظن السؤال ده. الإجابة هي
pain receptor.
البين تايب سي. نمشي للسؤال نمرة 15. which of the following statements about sensory modalities is not true؟ pain receptors are naked nerve endings، free nerve ending يعني.
صح
دائما
لكن ما الإجابة
البين بيكون free nerve ending، يبقى دي صح لكن ما الإجابة لأنه بنسأل عن النوت ترو. طيب slowly adaptive receptors are protective.
لا غلط.
ده كان نون ادابتيف ريسبتور. اوكي لكن برضه يعني برضه ممكن نقول سلولي ادابتيف ريسبتورز ممكن تعمل بروتكشن لانها ما رابد لادابتنج، وبالتالي ما حتكون دي الاجابه لانها كده بتكون كوريكت. T receptors convey information about distant events.
صح لكن ما الإجابة الدارينة.
صح لكن ما الإجابة. ممتاز. وبين is inhibited by stimulation of paraventricular area in the brain stem. دي في central inhibition of pain ما تكلمنا عنها. central inhibition of pain بيحصل بالبيتا اندورفين والانكفالين اللي بيشتغلوا ممكن في الجيت في السبستانشيا جيلاتينوزا، وممكن في البيري اكويدكتال اريا في الميد برين، و يعني including البارافنتريكولار اريا في البرين، ودي الاريا اللي بتشتغل فيها. وممكن برضه في السايت اوف انجري برضه released by immune cells او by nerve endings. فبالتالي في حتت معينه بتشتغل فيها الاندورفين والانكفالين، دي واحده منها، يبقى هي ترو لكن هي ما الاجابه. طيب first order neuron carrying vibration sense cross to the opposite side in the spinal cord.
First order neurons قلنا ال vibration sense part of the dorsal column tract it's the same side of the spinal cord. معناها دي غلط.
ايوه يعني بيكروس ذا اوبوزيت سايد في الميدلا في البرين ستيم. اوكي ودايما اللي بيعمل كروسنج للاوبوزيت دايما هو السكند اوردر نيورون ما الفيرست اوردر نيورون. الفيرست اوردر نيورون ما بيعمل كروسنج تو ذا اوبوزيت سايد، فلا في السباينال سلاميك تراكت ولا في الدورسال كولوم تراكت. دايما الفيرست اوردر نيورون بينتهي يا انتهى في حتته يا طلع سيم سايد وانتهى في الميدلا. يس دي اجابه الغلط، ويبقى دي هي الاجابه الصح. طيب Basinian corpuscles are only present in the skin.
غلط.
دائما only والحاجات زي دي يعني ما لم تكن متأكد من الإجابة دائما أخذها incorrect. are slowly adaptive.
برضو غلط.
دي بالذات الرابد لأدابتنج، لأنه الكبسول بتاعتها ما بتكون ضغط على النيرف اندنج، وبالتالي لما تضغط الكبسول حقتها ممكن الكبسول بحقتها تتحرك وتعمل ادابتيشن سريع زي ما بيحصل في التاتش، فبالتالي هي مسؤولة عن التاتش والتاتش رابد لأدابتنج، فبالتالي سلولي أدابتنج خطأ. There afferent synapse with second order neuron in the medulla.
صح.
Yes الافرنت طبعا هيجي طالع لحد المظلة. ممتاز. are stimulated by all synapse types of energy.
لا غلط.
هي ميكانو ريسبتور وبالتالي only الميكانيكال energy. their afferent synapse with second order neuron in substantia gelatinosa.
لا غلط.
لا ده الاسباينوثالاميك تراكت وهي تبع الدورسال كولوم تراكت. تمام. السؤال نمرة 17 concerning temperature sensation which of the following is not true. برضه دايرين not true. Receptors are free nerve ending.
دي صح لكن ما الإجابة
بالتالي ما
الدائرية.
الإجابة الصحيحة. تمام. لأنه البين والتمبريتشر بيتعاملوا مع بعض، الاثنين free nerve ending. Cold spots in the skin are 4 to 10 times higher than warm spots.
صح
الكولد
لكن ما الإجابة
ريسبتورز
الدائرية.
أكثر من الورم ريسبتور. صح، يعني ده الجسم بتاعنا يعني adapted لأنه to detect الكولد أكثر من الورم stimuli. Afferent for cold receptors of type A, delta and C.
صح لكن ما الإجابة الدائرية.
زي وزي البين صح لكن ما الإجابة الصحيحة. Busway is the ventral spinothalamic tract.
دي غلط.
دي غلط لأنه lateral spinothalamic tract زيه زي البين. lateral spinothalamic tract وبالتالي دي هي الإجابة المطلوبة. Afferent for warm receptors are type C fibers only. دي صح لكن ما الإجابة المطلوبة. تمام. نمشي لآخر سؤال نمرة 18 concerning position sense. Which of the following is not true? Depends on impulses coming from receptors in and around joints.
دي صح لكن ما الإجابة الدائرية.
تمام ممتاز. coming yes فدائما البروبريوسبشن بيكون موجود في الجوينتس والتندونز. receptors are Pacinian corpuscles.
صح لكن ما الإجابة الدائرية.
ما الإجابة الصحيحة. وعادة برضو بيكون في رافيني اندكس. برضو الرافيني اندكس اللي هي اكسباندد تيب هي الأنسب دائما للبوزيشن. receptors are known as muscle spindles.
دي غلط.
دي ما عندها أي علاقة وبالتالي دي غلط لأنه المسل سبندل دي في الموتور سيستم وبالتالي هي دي الإجابة المطلوبة. A large proportion goes to the cerebellum.
صح لكن ما الإجابة الدائرية.
صح أيوة. دايما البروبريوسبشن والبوزيشن سينس بيمشي للسنسوري كورتكس وجزء بيمشي للسيريبيلم عشان السيريبيلم يكون عارف الوضعية ويعمل كوردينيشن. Lesions result in sensory ataxia.
صح برضو لكن ما الإجابة الدائرية.
صح لكن دي ما الإجابة الصحيحة. تمام. بكده نكون خلصنا الحمد لله السنسوري. شكرا لك التجاني ما قصرت وإن شاء الله يعني التجاني أو any other student next time as you can see يعني ما في داعي للاسترس. يعني احنا just we are just revising our questions واللي بتكون عادة سهلة فهي فرصة برضو للطالب إنه يعني يتعرض لاسترس خفيف اثناء الاجابه وبيتذكر دائما. يعني لما تحاول تجاوب بتتذكر اكثر من انه لما تاخذ المعلومه باسفلي. لما تشارك فيها بالمناسبه بتقعد في المخ افضل. احنا هنتكلم عن الميموري also. الميموري needs some emotional stimulation so as to for the memory to be consolidated, for any information to be consolidated better. Relating it with emotional activation is better if you want to consolidate for a long time to create a long-term memory. Inshallah we'll talk about higher functions later. السلام عليكم يا شباب. See you inshallah next Friday. السلام.
شكرا جزيلا يا بروفيسور طارق على المحاضرة الرائعة جدا جدا.
يا دكتور عمار
واسفين جدا على
الشباب ديل. وإن شاء الله الشباب ديل يكونوا يعني عارفين إنه كاردياك سيرجن بيجي من المستشفى وشغال شغل very critical ويقضي وقت وبيحضر معاهم. يعني إن شاء الله يكونوا مقدرين يعني وعارفين الحكاية دي.
ربنا يديك العافية. وانت الاوثر بتاع الكتاب لما تشتغل معاهم شخصيا ما في عظمه اكتر من كده بالنسبه لهم يعني بس يشدوا حيلهم ان شاء الله.
الله يسلمك.
الله يديكم العافيه ونلاقيكم الجمعه الجايه ان شاء الله. واسفين على التاخير اللي اخرناك له اليوم. يعني ان شااء الله بنحل المشكله. المحاضره احنا في الاول عملناها اسمها اس بي ام اي ريفيجن ودي اسمها اس بي ام اي ليكتشرز في العنوان. لكن انا مسحت العنوان القديم وحاقفل الغرفة القديمة عشان تاني ما تعمل أي confusion إن شاء الله.